I'm Dr. Susanna Park from San Diego Fertility Center. Though we can't be present at the Kinderwunsche Tage conference in person, nonetheless, we could still share the information with you remotely. I hope this information will be very helpful in understanding the egg donor and surrogacy process in the United States. Our office is located in San Diego, California. And for those of you who are not familiar with San Diego, it's a beautiful city. It's always sunny every day, and it's located along the Pacific Ocean. And as you can tell by the photos, it's a beach city, and it also has a small downtown. This is our office. It's 2 stories. On the first floor is our operating room where we perform all our procedures. And on the upper level is where we see patients, do all our ultrasounds, and do our consultations. Many times people find the egg donor and surrogacy journey just confusing and very overwhelming. And this is understandable. But I like to break it down into 3 little parts. And I think and I hope that by breaking it down into small sections, it'll be much easier to understand and less overwhelming. So the first step is going to be the sperm. The second part is going to be creating the embryos. And the third part is going to be transfer into the surrogate. So let's go over each part step by step. Sperm. So the first part will be that we will send you a list of tests, blood tests and sperm tests to complete in your city with your own doctor. We will then review those tests. And the purpose of those tests is to get an idea of the status of your sperm. And it's okay if it's not perfect. We just want to make sure that you have sperm. And the purpose of the blood tests is to get an idea of your infectious diseases. And if there are any infections that can be easily treated, we want you to get it treated before you do the treatment. The next part with the sperm is getting your sperm to our center so that we can freeze it for the treatment. So notice I said to freeze it because it's easier if we have your sperm before we start the treatment, as opposed to trying to give us sperm that's fresh at the time of the treatment, because that requires a lot more synchronization and scheduling. Frozen sperm and fresh sperm have the same success rates. So it's just easier logistically just to give us your sperm before the treatment and we will freeze it. Before COVID, we welcomed you and encouraged you to come to San Diego. Come visit our center, come meet your team in person, and come visit sunny San Diego. But now with COVID, a few things have changed. So there are a few clinics in Europe that we have partnered with where you can go to the clinic and provide your sperm. But in addition to providing your sperm, in the United States, the FDA, which is the Food and Drug Administration, has very strict rules as to certain blood tests that must be done within 7 days of providing the sperm that will be used for the treatment. So with these clinics in Europe, we have created a program where the day when you provide sperm, they will also help you complete the FDA blood tests so that your sperm can be used for the treatment in the United States. Hopefully after COVID, you'll be able to come to our clinic and then you can easily just provide sperm and we will then complete all the blood tests mandated by the FDA. Step 2 is creation of the embryos. And the medical process that's required to make these embryos is called in vitro fertilization, IVF. So let's talk about that step by step. But in order to understand how IVF works, you first have to understand how pregnancy works. So an egg comes out of the ovary into the fallopian tube. So this is the fallopian tube. Sperm comes up through the vagina, through the uterus, through the fallopian tube, goes all the way to the end of the tube to meet the egg here. This is where the sperm and the egg meet. A fertilized egg we call an embryo. The embryo then has to journey through the tube in the reverse direction. And that journey takes about 5 to 6 days. And then it sticks in the uterus. Now let's talk a little bit about what happens in the ovary. So men make sperm every day until they die. Women don't make new eggs. Women are born with their lifetime egg supply, which is about 1 million. And then when women are about 50, 51, they run out of these eggs, which is when women go through menopause. But how do women go through 1 million eggs in 50 years? Because women don't ovulate 1 million times. Well, the answer is because every month, women lose many eggs, not just one. So let me explain. Here I drew the lifetime egg supply. The lifetime egg supply releases a hormone called anti-Mullerian hormone, AMH. And I'm going to talk about this hormone again in a few slides, so keep that in mind. From this lifetime egg supply, every month, a subset of eggs, so a cohort of eggs, leaves this lifetime supply and enters a competition. This cohort of eggs has a name, antral follicles. Without any fertility drugs of these antral follicles, one grows big and ovulates. Now, you cannot see these lifetime egg supplies on ultrasound, no MRI, it's impossible. However, you can see these antral follicles. And the number of antral follicles you see that grows big every month to enter this competition is a reflection of what's left in the supply. What that means is, if this donor has a lot of antral follicles, then you know, oh, she must have a lot of eggs left in her ovarian reserve, and therefore her AMH level will be high. But if you don't see that many antral follicles, then that means, she doesn't have that many eggs left in her reserve, so her AMH will not be so high. So one egg test is figuring out what's the AMH level. Another egg test is figuring out, well, how many antral follicles do you see in a month? And the third egg test is called FSH, follicle stimulating hormone. And this is another test to give you an idea if this donor has a lot of eggs left in her reserve or not. Now, what happens if you give fertility drugs? Well, rather than having just one antral follicle grow, the fertility drugs can make many of them grow, as is depicted in this cartoon that I made. But here is a very important concept to understand. Fertility drugs stimulate the growth of your antral follicles. So if your egg donor has an antral follicle count of about 20, then we're expecting about 20 eggs to grow. If your egg donor has an antral follicle count of about 14, then we're expecting about 14 eggs to grow. The fertility drugs stimulate the growth of these. Fertility drugs do not pull more eggs from here to enter the antral follicles. They only stimulate the growth of what the donor's body naturally pulled that month to become antral follicles. So you have various options for your egg donor. It could be a friend or family member, but most people will choose an egg donor from an egg donor bank. So we have our own egg donors. Now, these are not frozen eggs. Our egg donors have fresh eggs, meaning these young women will take these medications and give you eggs just for you for your treatment cycle. This is our egg donor website, eggdonors.com. Here is an example of one of our donors. This egg donor website is very transparent and we do not charge you to look at it. You simply have to get on the website and create a password. All the donors on our website are already medically cleared, which we paid for. And what that means is we performed all the FDA blood tests, all the ultrasounds, all the genetic tests, all the psychological screening. It's already been paid for by us, so you do not have to pay for it. If you choose to use an egg donor who's a family member or friend, or perhaps you'd like us to refer you to an egg donor agency, which absolutely we can, just keep in mind that you then have to pay for that donor to be medically screened. Another fact to keep in mind is because we're not a private egg donor agency, we're a medical clinic. We don't charge an egg donor agency fee, which is approximately $10,000. So using our egg donors saves you quite a bit of money. The third thing is many of our donors live local to San Diego, so they don't need to travel. Many donors from agencies live throughout the United States, and so you will have to pay for them to come to San Diego and stay at a hotel. So there's that bit of an expense to keep in mind, which would be the same if you used a friend or family member. Our donors have codes, which are letters, and we have some just demographic information about them: their eye color, their height, their hair color, their weight, their age, their blood type. We list a compensation here. Our donors have various compensations. If they're a first-time donor, they get less compensation. If they are a repeat donor, the compensation increases. But generally, we try to limit them to $15,000 maximum. In contrast to agency egg donors, the compensation generally is much higher. And it's the most important thing, there's no right or wrong. What's most important is that you find the donor that is perfect. And sometimes that does mean going to an agency. And we work with so many egg donor agencies and we'd be more than happy to refer you. Just keep in mind that that comes with an increased cost. But I believe it's worth the increased cost if that is the perfect donor for you. Our egg donors have a few types of relationships. There is anonymous. Anonymous means that you will not be able to contact her personally, but should there be a medical problem that arises in the future, you're welcome to let us know and we will then contact her. An anonymous relationship does not require a lawyer because we have legal contracts, standard contracts already written, and you sign it, she signs it, and nobody can make changes. So not needing a lawyer for this portion of the journey certainly saves you some money. However, there are two other types of relationships with our egg donors. One is semi-open, and semi-open means that you can contact her, but through a third party. So there's a website called Egg Donor Sibling Registry, and you would then contact her through that website. And the third option is open. Open meaning that you have her direct email. If you choose semi-open or open, you will then need to amend our standard contract, which would mean that you would need a lawyer to assist you with this process. And we can certainly refer you to lawyers who specialize in egg donor and surrogate contracts. In addition, we pay for the genetic screening results and we list the results there. So it's very important that the sperm source and the egg source don't have the same mutations. We all have DNA mutations. It's part of being a human being. But we need to make sure that you don't have the same ones, because if you do, there's a 25% chance that your child will actually have both mutations and be sick with the disease. And the majority of these diseases are diseases that can make your child very sick. So before you finalize your egg donor choice, we will send you a kit, and through a saliva sample, we can test you for DNA mutations as well. Now, there are thousands of mutations in existence, and we just don't have the technology to test for all of them. But we will test for whatever we can in the current year that we are testing. So at present, we're testing for a little under 300 DNA mutations. On our website, you will also find other information about the egg donor. If she's donated in the past, we will list all the information of her past cycles. And as you could see, the date is there, the number of eggs, how many are mature, how many fertilized. And if a transfer was performed, we will list the outcome of the transfers. Now, remember the prior slide, I had talked about some tests to look at the egg donor egg reserve. So here are those terms again: AMH, anti-Mullerian hormone. 4.89 is a fantastic number. Antral follicle count, that tells us a rough estimate as to how many follicles will grow and respond to the IVF drugs. And for this particular donor, we estimated about 47. And again, it's just an estimate. Now, all donors in our website will have good antral follicle numbers and a good AMH, because if they didn't, we would not have accepted them as our egg donor. But keep in mind that if you go with an agency egg donor, a friend or family member, we will then have to make sure that she has acceptable results for her AMH and her antral follicle count. Now, how do we create the embryos? So the egg donor will use medication to make all those antral follicles grow, but they are not pills. They are all injections. The needles are pretty short, probably about 2 centimeters, and she injects in the fat layer of her abdomen. She does it herself. We teach her how to do it. It's rather simple. And she injects every day for approximately 10 days. The range is about 9 to 12 days. And during that time, she needs ultrasound and blood work every few days, probably about 4 times. And the purpose of these injections is to get multiple antral follicles to grow. So remember, without these IVF drugs, here's her ovary. These are the antral follicles. And without the drugs, only one will grow naturally. But with the medication, the hope is to get all of them to grow so that her ovary will look like this. Once the eggs are ready, it's time to get them out. So we have an operating room on the first floor of our office. She is put to sleep with anesthesia, which means she's not in pain during the procedure. We take the eggs out vaginally. We do not cut the abdomen. It comes out through the vagina. So this is the vagina. Here's the uterus. These are the fallopian tubes. And here are the ovaries. And we go from the vagina, and then the needle here passes directly into the ovary. And there's one egg in each follicle. And the process takes about 30 minutes. So here's an ultrasound picture of the needle going in. But here's a video of me performing an egg retrieval. So here's the ovary. Every black circle is a follicle, and inside is the egg. This is my needle. It goes into the follicle, and I step my foot on a suction machine. Now it's black because it has liquid in it. It takes out the liquid into a test tube. The test tube is handed off to an embryologist who looks under the microscope and tells me, yes, there's an egg, or no, there is no egg. As you can see how quickly we move, it's a rather simple procedure. And this is an egg donor. You can tell because she has so many follicles. The day of the surgery, the thaw, the sperm, which was frozen, is now thawed. And we fertilize through a method called ICSI. which is intracytoplasmic sperm injection. And what that means is we take one sperm and we put it into one egg. Now, if there are two sperm sources, we will then divide the eggs. And the most common division is 50% of eggs goes to one sperm source and 50% to the other. But it doesn't have to be 50-50. Depending on the circumstance, you may choose to do 70% to one sperm source, 30% to another. But the beauty of this is that if you do have two sperm sources, you don't need to do this 2 times, hopefully not. In the ideal situation with one harvest, egg surgery, you can divide those eggs between 2 sperm sources. So this is a picture of what natural fertilization is. In the natural world, you have one egg and millions of sperm around it. And of those millions of sperm, one sperm will fertilize the egg. Survival of the fittest. However, in ICSI, we take one egg and we put one sperm inside. Here is a video from our lab. Here is the pipette grabbing the sperm. So they immobilize the sperm by cutting the tail, and then we grab the sperm. And now we have to look for the egg. So onto another dish, you could see the eggs. So one egg is selected, and it's held in place by this pipette. Now the egg is in place, and here is the pipette with the sperm inside. The pipette will then pierce the egg. The sperm is being put in position. We drop some fluid from the cytoplasm of the egg. And the sperm is then being injected right there. And the pipette is pulled out. ICSI is performed on every single egg. So you can imagine that if a donor has 20 eggs, this procedure has to very precisely and carefully be performed on every single egg. And oftentimes people ask, my goodness, why is this process so expensive? And it is expensive. But when you look at videos like this, you get a glimpse as to the amount of skill, equipment, very expensive equipment, experience, time that goes into creating optimal embryos. Fertilized egg we call an embryo. The embryos are grown in the laboratory for 5 to 6 days. So remember earlier when we talked about how pregnancy works, I talked about how an egg comes out of the ovary, goes into the fallopian tube, sperm meets the egg here, and it takes 5 to 6 days for it to journey through the tube to be the right stage of development to stick in the uterus. So it is for that reason we wait 5 to 6 days in the lab. So here's 1 day old. You can see the 2 sets of chromosomes, one from the egg, one from the sperm. 2 days old, it's 4 cells. 3 days old, 8 cells. 4 days old, 5 days old. By 5 days old, we call it a blastocyst. because it has a fluid-filled cavity here called the blastocele. And by this stage, it has over 100 to 200 cells. Now keep in mind that not every egg will make it here, because not every egg that gets fertilized with sperm becomes an embryo. The fertilization rate is about 60 to 80%. And then not every embryo survives days 5 to 6. Only the strongest will survive. So be prepared for what we call an attrition rate, meaning that with every step, you will lose some. Now, when your embryo is 5 to 6 days old, we will freeze it. But right before we freeze, you have an option of a test called pre-implantation genetic testing for aneuploidy, PGT-A. And this is a test that tells you two things. Number one, the number of chromosomes, and number two, the sex. So when you have an embryo, 23 chromosomes come from the sperm source, 23 chromosomes from the egg source, for a total of 46 chromosomes. So here is chromosome number 1 copy from the sperm, 1 copy from the egg. Chromosome number 2, 1 copy from the sperm, 1 copy from the egg. Chromosome number 3, 1 copy from the sperm, 1 copy from the egg. On and on. Chromosome number 23 is a sex chromosome. X chromosome, Y chromosome, meaning this is male. If it was X and X, it would be female. So PGT-A tells you the sex and the number of chromosomes. So here's an example of Down syndrome. Chromosome 21 has 3 copies, 1, 2, 3. So because this is not 46 chromosomes, this has 47 chromosomes. It is not a normal embryo. If you choose PGT-A, right before we freeze the embryos, we will biopsy each embryo. If you choose not to do PGT-A, then we will just freeze them without a biopsy. If you opt for biopsy, this is just an example of what the biopsy is. This is your embryo, your blastocyst. This is your fluid cell called the blastocele. And we're taking the cells, not from the actual baby, but from the outer ring called the trophectoderm, and that outer ring is the future placenta. So we take out about 4 to 6 cells. Now notice this little red circle, that is our laser. So with a laser, we cut in between the cells to take out about 4 to 6. People often ask, gosh, doesn't this damage the embryo? The damage rate is reported to be about less than 1%. Right, now on to step 3, transfer into your surrogate. So surrogate can be a friend or family member, but most people will use an agency. We will refer you to various surrogacy agencies. And there are certain criteria that a surrogate must meet. She must be between 21 and 45 years old, at least 1 uncomplicated pregnancy, less than or equal to 5 deliveries, less than or equal to 3 C-sections, a stable family, and we have a weight restriction. We would prefer your surrogate have a body mass index of less than 30. If she's a wonderful surrogate, we may be lenient and raise this to 32, but ideally it would be great if her body mass index was less than 30. 30 is considered obese. We will then review her history. She must undergo psychological examination, and then she will undergo various physical examinations, drug screen, and infectious diseases. And of course, we'll make sure her uterus is normal. This is the uterus that is perfect. This is the muscle of the uterus, and this is the inside, which we call endometrial cavity. And we want it to be perfect like this. Notice here that your surrogate has something growing in there, which is a fibroid. And this will then just be surgically removed, and then she could still go on with the surrogacy process. Your surrogate will take hormones, estrogen, which are most commonly pills, but they're also in the form of patches or injections, and progesterone. Progesterone helps to make the endometrium, which is the inside of the uterus, receptive to implantation. And our preferred method of progesterone are injections. But these are not tiny injections like your egg donor used. These are big needles, a couple centimeters long, that she injects in her butt every day. And if she's pregnant, every day for 3 months. It's quite a commitment. With these hormones, she will have an endometrial that's 8 millimeters thick. And we want to see this triple layer pattern, which is the 3 white lines. 1, 2, 3. That is what we are aiming for. Once her uterus is ready, we will then perform the transfer. So the embryo transfer is performed while wide awake. It does not hurt. There is no need for anesthesia. So a catheter is placed through the vagina into the uterus, and an embryo, not sperm, this is not insemination, an embryo is placed into the uterus. Now you have the choice of transferring 1 embryo or 2 embryos, and if there are 2 sperm sources, yes, you can put 1 embryo from 1 sperm source and 1 embryo from the other sperm source at the same time into the surrogate. Having said this, I would like to tell you that the healthiest and the safest pregnancy is to transfer 1 embryo into the surrogate. Because if you transfer 2, it's not a guarantee of twins, but there is the chance of twins. And twin pregnancies have higher potential complications compared to a singleton pregnancy. But in the United States and at our clinic, we do offer the option of 1 or 2. Here's a video of me performing an embryo transfer. This is the uterus. This is that thick endometrium. And this white line is my catheter.
Going to that white patchy area. One embryo.
Look right there.
See that flash?
Right there. So there's a white flash.
Right there.
And that's the embryo in the uterus.
Your embryo in your uterus. We're done.
It's a very simple procedure. And because most of our intended parents don't live in San Diego, you are more than welcome to FaceTime or WhatsApp during the transfer. If the time, because of the time difference, may not be convenient, then we can certainly videotape it so that you have it for your record. About 2 weeks after the transfer, the surrogate will then have a blood test to confirm if she's pregnant or not. And if pregnant at this point, she's about 4 weeks pregnant. And I know everybody finds this confusing. And the reason for that is when people calculate how far pregnant a woman is, and let's say she just got pregnant through sex, nobody calculates based on when she conceived that embryo to when she does the blood test. The calculations are always done when she started her period. And so we have to adjust our IVF dates to match with that schedule so that when your surrogate is pregnant and she goes to her doctor, the dates all match up. So when she finds out she's pregnant, she's already 4 weeks pregnant. And about 2 to 3 weeks after the blood test, an ultrasound is done just to see the pregnancy, make sure there's a heartbeat. So this is the uterus. Now inside the uterus, there will now be a black circle, and that's the pregnancy sac. We call it a gestational sac. Then there's a little white ring called the yolk sac. This is what gives your baby nutrition because the placenta is not developed yet. And right here is your baby. And if this was in real time, you would see a little flicker, 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 which would be the heart beating. Now, sometimes, even though we transfer one baby, it could split. And that's when you have a set of look-alike twins. We call it identical. So the way you know is that there is one sac, but inside the one sac, you see two yolk sacs and two babies. Here's one baby, here's the other. And they would each have a heartbeat. The chance of an embryo splitting is less than 5%. If I transfer two embryos, that means you have the risk of twins, but those are two separate babies. So they're not identical, right? We call them fraternal. So the way it looks on ultrasound is each has its own little black circle. So here's one gestational sac, here's another gestational sac. Whereas here, there was only one gestational sac. And inside each gestational sac, you have its own little yolk sac and its own little embryo. Okay, so these are twins not look-alike. They came from two separate embryos. These are twins look-alike because they came from one embryo that's split. So that is the end of the explanation of how to do egg donor and surrogacy in the United States. I really hope that you found this presentation helpful, and I hope it was very clear. And if you felt overwhelmed in the beginning, I really hope that keeping in mind that doing it step by step really helps to make the process just much easier. If you have any questions at all, feel free to email me. This is my email, spark@sdfertility.com. And this is my son, who's now 8, when he was a baby. Thank you so much for your time. I really appreciate it. And I hope to meet you one day soon in person.